Now, if you'd asked me what the second most interesting thing that ever happened to me was, Who the security people were? No, it just said suspect, said 28. Of 13th and I. We go through batteries by like the hundreds.
Good morning. Good morning, everyone, and welcome to the Bipartisan Policy Center. I think we're competing against a impeachment hearing going on the Hill, but good morning and welcome to the Bipartisan Policy Center. I'm Bill Hoagland. I have had the pleasure over these many last few years working with our BPC health team on several issues. Before I turn it over to Catherine Hayes, our Director of Health Policy, I want to highlight the fact that we are dubbing this week at BPC Health Week because besides this event here this morning, we're having two other events tomorrow and the following day that deal with health issues. If you're interested, tomorrow we are discussing the role of patent policy in the ongoing debate of prescription drug pricing. And on Wednesday, we have representatives from the White House as well as HHS coming here to talk about the Stark and anti-kickback laws, and all again as it focuses on health and health spending and prices. And while I'm at it, I'm going to give you a highlight of something to look ahead important, and that is ahead in 2020. On February the 5th, we will be releasing recommendations from our over 2-year study from our bipartisan future of health work. And this was co-chaired by former senators and former majority leaders Tom Daschle, Bill Frist, along with former acting director of CMS Andy Slavitt and former director Gail Walensky. Your moderator here this morning, Sheila Burke, is a member of that and has dedicated an awful lot of time in the production of that report. So I put it so I don't think it's an event you want to miss. It coming during what is clearly going to be a very, very tumultuous year, election year, focused on health as one of the major issues that the public are concerned about. Today, however, we're going to discuss how to advance comprehensive primary care in this very important federal state program. Just a refresher, you're all experts, you know this, but the Medicaid health insurance program serves over 75 million low-income Americans. 31 million of them are children. As an old budgeteer, I have to focus a little bit on cost, and it is cost the federal government about $400 billion annually. And that's expected to continue to grow, at least to current projections, at around 5.5%, 6%. And of course, since this is a state-matched program, federal expenditures are added to about $250 billion from the states, bringing the total cost of this program to the public close to $700 billion, which is quite interesting, is almost equivalent to what we spend on the full Medicare program totally. So how to ensure that the recipients particularly, as well as the federal taxpayer, is getting the best value for these expenditures is the focus of this discussion today. When done well, I understand that investments in primary care improves outcomes and at the same time reduces costs. As an example, it's given to me by the staff, is in Oregon, for example, the state's patient-centered medical home program demonstrated that, at least by their estimates, for every dollar they spent there, they saved $13 in the program. Pretty good return on the investment. So now, without further ado, let me turn it over to Catherine to further set the stage for our discussion today. Catherine?
Thank you very much, Bill, and I'd like to add my welcome to his today. Appreciate you very much your being here. And just by way of background, what we're trying to do here, what we've been asked to do, our funder is the Commonwealth Fund, is to take a look at the barriers to comprehensive primary care in Medicaid. So we'll be looking at policy barriers, regulatory barriers, and statutory barriers. Trying to say all of that is a challenge. Trying to get all of that together and look at how we might mitigate those barriers. So our leaders will be coming out with a report in July of 2020. This is the second in a series of events we are having on comprehensive primary care. The first was back in October. It was a private roundtable discussion with experts from around the country to talk a little bit about what they perceive as the barriers and possible options. With that, I'd like to introduce Lori Zephyrin, who is the Vice President for Delivery System Reform with the Commonwealth Fund, to make a few remarks.
Thank you so much. Thank you all for being here today. I just want to talk briefly as to why this is a priority area for the Commonwealth Fund. Just personally, as a physician and as a person that's spent my life focusing on delivery system transformation for vulnerable populations, primary health care is a key foundation of our healthcare system for all Americans. And our focus in the vulnerable populations work at the Commonwealth Fund is to really ensure that low-income populations receive high-quality, comprehensive primary health care. And really the goal of this work is to really highlight opportunities and explore barriers and determine strategies to mitigate those barriers so that we can really enhance and improve and implement primary health care across our healthcare system. I just want to talk a little bit about what the evidence shows briefly. We know that income inequality promotes negative health outcomes. We know that race can be a driver of worse quality health care and a lack of receipt of preventative care. And high quality primary health care really mitigates the negative impact of income inequality and reduces racial and ethnic disparities in physical and mental health. And so there's really a significant opportunity for delivery system transformation by thinking of and incorporating new models of delivering primary health care, and also really ensuring that we implement high-quality, comprehensive primary health care and accelerate the successful evolution of this care. When we reviewed the literature, I just want to really end with some key attributes of high-quality primary health care. I really want to emphasize the health in primary health care. It's more than just primary care, really thinking of health care that incorporates community health, incorporates the community, integrates public health and social services and social determinants of health, integrates behavioral health, really thinks through digital modalities and other modalities to make it more convenient for the population and people we're trying to serve, and really ensure that we're engaging patients and families in this care. So thank you all for being here. Really excited for this work, and this is really a key priority area for the Commonwealth Fund, and really looking forward to next steps in this work with all of you. So thank you.
Thank you, Lori. I'd like to invite our panel to come forward at this time. Today we have our moderator, Sheila Burke, who is also, she is a senior advisor to BPC, one of our leaders on our Future of Health project, and a strategic advisor at Baker Donelson. Patty Barnett, on the end, Vice President of Health Policy at Centene. Sean Martin, who is the Senior VP for Advocacy, Practice Advancement and Policy with the American Academy of Family Physicians. Tricia McGinnis, Executive VP and Chief Program Officer with the Center for Healthcare Strategies. And then Hamy Tuwarson, the Director of the Center for Best Practices Health Division, National Governors Association. Thank you so much.
Thank you, Catherine. Welcome to all. We're pleased to have the opportunity to talk with you today about Medicaid. Let me begin where Lori sort of left off in talking about what we believe primary care to be. And then we'll talk primarily about, and most importantly, about what the barriers are to achieving those goals. When we met in October in a roundtable to have a conversation about primary care, we identified the following as the critical elements of a successful primary care system. One is an interdisciplinary team, excuse me, of healthcare professionals that includes a wide range of providers with different expertise. Community health workers are among them, as well as physicians and nurses and others. Critical to the team, that it has to be an interdisciplinary, well-organized team. Secondly, the integration, which Lori touched on, of physical health, behavioral health, oral health, and social needs, that we can no longer think of those in terms of silos as to what in fact comprises a full primary care set of services. I like to think that if you can't chew, you can't eat. If you can't eat, you can't maintain your health. I mean, there are a wide range of things that we need to think about. Understanding the relationships with specialty providers, that we fully integrate across the full array of providers when looking at the development of primary care. Patient and family engagement, as Lori pointed out, it is critical that we think of the family as the most critical element in many cases in terms of providing services and supporting individuals. Community engagement, that the community in fact is fully bought in and recognizes in investments the nature of what needs to be developed in terms of partnerships with community development agencies. The screening and assessment of people's social needs and their referral to the appropriate providers is a critical element of that. Diversity, equity, and inclusion, that in fact the issues that Lori pointed out, we must recognize that there are serious distributional issues that are not simply geographic, but even within urban areas, things are not readily available. The continuity of care that supports the transitions in care. One of the greatest challenges is, in fact, as people move through the system and making sure those transitions take place and they are coordinated so that a person coming into the system has someone to assist them translate through that system. We want high-value care. Measured high-value care is a critical element of that provides outcomes. And we want to use data to essentially assist people to track what's occurring, to recognize what in fact is value, and how best to distribute services, and the use of technology, and how important the use of that technology is in the provision of services. And it's everything from telehealth to the ability of a provider to track essentially who's caring for a patient and how best to meet their needs. So those are our goals, which are complicated, and are in various states of success depending on the programs. Hopefully we'll hear a little bit about some of the best practices in our conversation today, about folks that are doing it well and how they're doing it well. And so as we look at our goals, we also need to look at what the barriers are and essentially what's preventing us from achieving those goals. And we have 4 terrific folks here with us today to begin to help us think about that. Where are the barriers? What, in fact, there are some obvious ones that came up in the context of our conversation in October, but we want to probe those a bit in terms of figuring out what, in fact, we need to do and where the investments need to be made. So I'm going to begin there with our panel, which represent a wide range of experience and background and knowledge. I'll note that Patty will talk with us about their experience with Centene, and I will underscore that Centene now works in 24 states and covers 8 million Medicaid beneficiaries. So real experience online. We'll talk to Hamey about how the governors view this issue. And where does it fall within all of the other challenges that the governors face? And what are the tools? And we'll talk with Sean about what unique challenges the providers are really facing and how to think about that. And then Tricia, essentially she's had experience at Blue Shield, I should say, California, as well as now being at the Center for Healthcare Strategies as to what their experience has been and what their models are. So let me begin with a question to all of you. What do you believe to be the greatest barriers? What's preventing us from making progress in each of these areas? Let me begin with you.
Sure. So I really think a lot of it is, provider care, primary care provider shortages throughout the country. That's a big barrier. I think it's the ability for individuals to engage with those providers. So maybe they're assigned a provider, but they have difficulty getting to care. We call it social determinants of health, but it's that's a long-standing issue of people being able to have the transportation, being able to meet their basic needs to get to care. And I think the other piece for us that we see is just the integration. And I know the challenges of not having behavioral health be able to connect it to physical health and some other carve-outs that I think we're experiencing. So those be the big ones for me.
So the obvious question, Sean, in follow-up to that is, what is in fact the provider shortage? Is it a a function of people not choosing that as a specialty? Is it that the reimbursement structures aren't sufficient? Is it a lack of recognition of the range of providers, whether the scope of practice laws have inhibited? How do the physicians view this?
Yeah, I think, well, it's a good question, and thank you for having me here today. So to your specific question, I think when you think about workforce shortages, I think the first thing that we draw our attention to is really the distribution of the workforce, and then the connectivity to the workforce that may not be face-to-face. And I think we're beginning to think about that differently. The old traditional, you go to the office to receive your health care is being re-examined, and are there ways to access primary care that do not involve a physical face-to-face type of visit. We are very careful, the Academy, it takes everyone. There is enough need out there that it takes everyone, and I think defining roles, defining how those roles contribute to each other versus compete with each other is an important part of how we're going to begin to address some of the access problems, particularly in Medicaid. I think the other piece is really needing to accelerate the way we think about paying for primary care. It is not a per-service endeavor. We need to think about primary care being a comprehensive set of services, and we need to imagine comprehensive payments that facilitate the delivery of those services, not pay for episodes of care. And I think, to your first question, the greatest barrier right now is, I think, how we pay for primary care, particularly for vulnerable populations. We do it on an episodic basis. We really need to think doing it on a prospective, kind of global or capitated basis moving forward.
Well, we know that a good percentage of the Medicaid program is currently in managed care. North of 70% are in managed care arrangements. And so what has failed in that context? As we've moved to managed care, what's preventing that integration? As we look across the services, as we're putting people into those managed care relationships, what's stopping the kind of integration that you're talking about?
I can't believe I'm going to say this, but I'm going to say it anyway. I think there's a lot of downward pressure on the managed care organizations, particularly the way state legislatures or the authorizing entities manage the money that flows through the managed care. So the managed care organization may be very robust, Centene may be robust in how they view delivery and comprehensive primary care and how they want to pay for that, but they may be restricted by rules that are put in place by the governing agencies within their state that make that more difficult. Prior authorization, segment of benefits for mental and behavioral health. Maybe they completely carve out dental. I mean, some things are beyond their control in some environments. I think the other thing, it's a trusting relationship. The managed care organizations have to begin to trust that a prospective capitated payment to primary care for a population of patients is going to be beneficial to the beneficiaries themselves, but also to their fiduciary responsibility to administer the program. And we just have to get there.
So I want Hammy and Tricia to have a chance to comment on that. One, because you've referenced government, I think governors, when you think of government, and what the role and how this is placed in terms of order of priorities within the states, but how they're thinking about it, and essentially how, from a strategy standpoint, is that the answer? Is it a question of the structure of a managed care? Even under managed care, it's mostly fee-for-service at this point. It's not a fully capitated in real-world global budgets. So, Hammy, Tricia, what are your thoughts?
Sure, I'm glad to kick it off. And just to be clear, my remarks from the National Governors Association, I direct health in the Center for Best Practices. So in the Center for Best Practices, we work with states to really identify what are the models they need to understand from across the country and how can we move policy forward. So I am not the lobbying arm of NGA, I am the center of NGA, Center for Best Practices. So all of my remarks are based on our work with states. So in response to that question, from a governor's perspective, they don't talk about primary care as one of their priority areas, as a top line. But they talk about how do we improve value in the system? How do we reduce cost and improve outcomes at the same time? And that is true. We are bipartisan at NJ. We represent all governors. Our chair is Governor Hogan from Maryland. Our vice chair is Governor Cuomo from New York. And across Democratic and Republican governors, they have very similar goals in that respect. How do we drive more value into the system? Medicaid, a per member per month is an efficient program, but it is also such a big part of their spend. An average of 29% federal and state dollars combined of a state budget. So it's always a topic of conversation. How do we drive more value? But to get back to your question, I think, some of the things that rise to the top, behavioral health integration, we hear from governor's offices. We just had our meeting in September with the governor's offices. That came to the top. That was their top priority of behavioral health integration. Second was cost and value. And primary care is an integral piece to all of that. Opioids and addiction was third. Really thinking about these things in a holistic way has to involve the primary care physician. And the thing I would respond specifically to your question about, managed care and how does that work with primary care doctors, as we talk about behavioral health integration, we talk about addressing the social determinants and how do we get, access to things like supportive housing and supportive employment, which can then improve the overall outcomes of the population. Primary care is going to be key to all of that, right? Because they are where some of these complex populations are going. When we did our complex care work, it was like, how do we engage the primary care offices and those other support services in a meaningful way? And from our perspective, again, we're at the system level, not at the ground, closer to where Sean's folks are. Is the infrastructure there? And I think, as we get into the conversation, we talk about some of the models that are out there where there has been some advanced primary care work. There has been investments in infrastructure and changing the practice of the delivery of services, because it can't just be the payment piece. There's got to be an investment in how the office works, because I think some of the, especially the smaller physicians and some of these other community care providers, they may not be ready for a capitated payment. They need to have support to move to that transition. So I would love to talk more about that in this conversation.
Good. Trish?
So in our work at the Center for Healthcare Strategies with state Medicaid agencies, they are very interested in this question of how do they leverage their purchasing power and their partnership with managed care plans to drive more investment in primary care, but figure out how to best support both the managed care organizations and the primary care organizations in ways that make sense. So for example, one state that has both prioritized primary care at the governor and at the state level, Delaware, they are experiencing shortages and drops in the number of PCPs in their state. And so they've taken a really effective multi-pronged approach. They've set healthcare spending benchmarks across the state and across all payers. Medicaid pays at Medicare rates, equivalent to Medicare rates. So the playing field is level for payment. But they're layering on top of that requirements for their managed care organizations to enter into value-based payment arrangements. And they're beginning to explore not only how to transform payment, as Sean was talking about, toward more capitated, holistic payments for primary care, but then pairing that with risk-based contracting for the hospitals. Because it's difficult to invest both in primary care while also not tending to the higher cost areas of the hospital. So they've taken a really smart kind of multi-pronged approach. But I agree with Hammy too, providers aren't ready necessarily to enter into capitated plan arrangements. And so states are looking to figure out how to partner with their MCOs in ways that create aligned investments that the primary care practices can then dip into. So for example, in Hawaii, they're going to create enhanced referral networks at the community level. In Hawaii, they have really small primary care practices, and it's not feasible for them to integrate behavioral health care into the primary care setting, but it is feasible for them to work within a broader network in their communities. And so looking at the MCOs and the state to really create a structuredized approach at that community level, that's one of the things that they're implementing through their managed care contracting to help address some of those problems.
So let's examine two of the issues that you've raised. You've all touched on payment. Of course, we had the bump up that occurred for a couple of years. To what extent was that in the least bit effective? To what extent have states maintained that? Why not? We talk about investing in infrastructure. What is that? What do we mean? What is it that we would be asked to invest in that would have an impact? And we've talked about essentially shortages. some of which are geographic, certainly in rural areas, but also even in inner cities, you see shortages. So let's probe for a moment. What happened with the bump? I mean, in terms of payment. Was it in fact taken up? Was it viewed as successful? Did it in fact have a result of more people participating? Why not, if not? And what's the next step in terms of payment and how we think about that?
So there were conflicting results from the primary care bump. I mean, it was very flawed. It was only for 2 years. People knew it was going to end. It was very complicated to implement. One study found that it actually did improve access, that it improved, that it lowered cost, it improved connectivity of patients. Another study, though, found that it didn't necessarily increase the number of providers who were accepting Medicaid, which to me suggests basically that it was affecting Medicaid providers already serving Medicaid and expanding the access of those providers to serve greater numbers of folks. And so to me, that suggests investing in the current capacity of the providers who are already serving Medicaid rather than prioritizing getting new providers to be part of the Medicaid program. So there were 19 states actually that did continue the primary care bump. And one of the many limitations of the bump when it was implemented was there was no tie to value. And so what a lot of those states did was take that bump and then figure out ways, Colorado did this, how to take that increase and really tether it to increases in quality, increases in access, and really leverage that as a roadmap to VBP. And I think as we talk about how to increase capacity for capitation payments that are going to ultimately give more flexibility, thinking about that rate increase and that as a building block to kind of greater value-based payment. I think it's a good example of what some states do.
Other comments?
So our internal survey showed the same thing. I think the Medicaid bump from the ACA rewarded the committed for the most part. I think it did expand panel size. So I think if there were, in any given office, if they were running, 25% Medicaid appointment slots, that likely increased as a mix of their panel. But I don't know that it brought non-Medicaid participating family physicians into a participating status out, in any measurable way. I think there were probably a few, but I don't think it was a measurable outcome. I think the other thing which was mentioned is the program. There were a couple states that they, were in the 9 to 12 months of actually getting the money because the rollout was so delayed and flawed that it's kind of hard to tell what would have happened if it would have been rolled out in a more, efficient manner.
Amy?
The only comment I would make is talking to some of the state leaders about payment to primary care practices, not necessarily just related to the bump, but just more broadly. There's an interest in how do we do this across Medicaid and commercial, and how do we think holistically about investing in sort of primary care medical homes, patient-centered primary care medical homes. And if you think about the Rhode Island example, where back in 2010, this was on the commercial side, where the Commissioner of Insurance said, okay, you plans, in order to get your rates approved, you actually have to increase your investment in primary care, but you cannot do that by increasing payment, like the actual rates that you pay to the providers. You actually have to increase your investment, so utilization goes up, and the actual investments you're providing to the providers goes up. And at the time, I think there was a lot of pushback where we're going to lose specialty care, and it's not going to make a difference on the primary care side. And I think over time, they've really seen some good results with that investment. And there's been payers like Blue Cross Blue Shield that serve both commercial and Medicaid that have made significant investments in primary care. And they've made PMPM payments, per member per month payments to primary care physicians for infrastructure and meeting targets. So they've seen a huge increase in their primary care capacity, and they have not seen any decrease in specialty care. So I think this concept of, let's move beyond just the payment itself and tie it to the value, payments for infrastructure, payments for quality, and see how that can change the trajectory.
And in that context, what is infrastructure?
That can be supporting them with their electronic medical record
Okay.
systems.
Right.
That can be helping them understand their referral networks. That can
Okay.
be helping them with, do they have the claims processing capacity? I mean, there's a lot of different things. I don't know, Tricia, if you have anything to add, but just some of the nuts and bolts of how their practice can transform to really be more patient-centered and also have referrals to other social services, which sometimes doesn't happen.
Right.
And telemedicine.
Telemedicine, yeah.
Right.
It raises an interesting question, though, because what it doesn't seem to touch on is the network and how, I mean, the point made about Hawaii or any other small practice, that essentially saying that you need to integrate behavioral health or the sort of broader range of services and not exclude or leave out the specialty relationships that are also critically important. How do we essentially overcome this barrier that seems to have been created in these silos, either as a result of carve-outs, whether it's pharmacy carve-out or dental carve-out or mental health carve-out? How do we overcome that and essentially develop these systems? Because one of the challenges with this population is they churn. They come in and out, either in and out of plans, in and out of eligibility. So the investment, one wonders, am I going to get a return on the investment if these folks are going to bounce in and out every few months or every year? So how do we essentially get an investment in the relationships, particularly in those small practices? How do we get to that? How do we lower those barriers to including behavioral health, which we know is a critical part of this?
So I think from our perspective, I think first and foremost, we would promote fully integrated care. We cannot really do our job well if we are not able to treat the whole person. And so, I think it really starts with a strong engagement with the provider level. And also, behavioral health shortages are also is a big issue we should probably talk about. One way that we've tried to bridge the gap is, through investing in telehealth, virtual care infrastructure for access to behavioral health services through that mechanism. We also, with our provider relationships, we really, to everybody's point, we really started to invest in more value-based arrangements, but also thinking not just, because it's not really just about payment, it's providing how can we help you provide referrals to community services. I think what's really, what I'm most excited about from our perspective and our scale, because you heard 24 states, over 8 million people, is that we are able to have a scale to be able to aggregate community-based organizations and be able to connect primary care providers, give them the referrals for their patients to various services to help with housing, to help with food. So I think just really trying to be a partner and trying to integrate the community as well. And then leveraging technology where we can is how we are trying to address it.
So, Hammy, I want to, just as we think about the expansion or looking at providers, and Sean, you may have a point of view on this as well, we recognize as important as primary care physicians are and family practitioners are in that context, non-physician providers. What is it, in fact, that's occurring? I mean, given the issues that exist with respect to scope of practice and the sort of barriers that have been set up to fully allow nurse practitioners and others to practice at the full extent of their license. To what extent is that being seen also as a strategy in terms of both in plans and the plan development, how they think about it, and how we begin to look beyond essentially the physician, critical element, but beyond the physician to other providers?
Yeah, no, it's a great question. And the Rhode Island example I was talking about, one of their focuses was also on community health teams. So how do we incorporate not just the primary care physician themselves, but other folks on that team to actually provide some of the holistic care? I will say, taking a step kind of away, not just at nurse practitioners, but also looking at community health workers, who's out there doing the housing work, who's out there doing the supportive employment work, who's out there actually doing some of the social services. Because when we did our work on complex care populations, which has been over the past number of years, 4 or 5 years, and we were trying to figure out, okay, in the Medicaid program, how do we really get more value in the program? Can we focus on the ones that are in the most need? It would be hard to serve those folks with just, telemedicine visit. I mean, it actually had to be a face-to-face patient encounter and then an actual referral to those services. And I think to follow up on Patty's point about how, how plans can engage some of those other providers, it's challenging. Some of those providers are paid by block grants. They may not be billing Medicaid. I mean, you have to bring in a whole different host of players into the system. And I've been in a couple of these conversations, and we're like, let's not totally industry push these providers and make any mistakes doing that. Let's think thoughtfully about how we engage them because they may be in different places. And I think one thing that we've been thinking about does it make sense to have a more systematic way of thinking about those providers at the state level, and how much should a state push a managed care plan, I mean that in the gentlest way, Patty, to be thoughtful in their engagement with these community providers. North Carolina, of course, we've been talking about North Carolina and see where they're going to go with this. But they have a real interesting plan of let's have a uniform way to refer patients, or actually individuals, to these community providers, and let's have a more systematic way of making those investments. And it's interesting for them because they're doing it statewide. States have been doing that in pieces, but North Carolina's kind of taking it all at the same time and trying to do it all at the same way across all their plans, and they're rolling out managed care at the same time. So it's a long way to answer. I think there has to be a lot of thought put into how you engage these other types of providers in the way that they're going to be paid and come into the system. So.
Sean, you were going to comment?
Yeah, so I'm going to try to thread the two questions here. So I think the first thing, and not to make news here, but I think we need to fundamentally reimagine how we think about primary care, particularly with vulnerable populations and others. And we tend to view it as like an additive process. Like, we want them to do behavioral health, we want them to do telemedicine, please do home visits, please do community care, please do population health. I think we need to just tell them, we're going to make primary care as comprehensive as possible, and when you are no longer comfortable doing something, then we'll figure out how to get beneficiaries those services. And we've been doing some research here. How can you use artificial intelligence, machine learning? How can you disseminate information down to primary care to maximize every dollar spent at primary care to the extent possible? And we use the word the plasticity of primary care. Like, they can do a lot of things. Let's let them do a lot of things. And let's do that through a payment model, and let's do that through a kind of a rollback of the sub-regulatory structure with how they do it. So don't limit their telemedicine visits to 2. Just say, we're going to pay you to do telemedicine in your office. You do it however you think it best serves your patient population that has been attributed to you. I'll go back to my earlier comment on kind of the non-physician, physician scope of practice battles. I think there's a lot of commonality. We have done so much research on this. Regardless of state licensure laws, the migration of providers of all types seem to mirror each other. So expansion of scope of practice laws often have a spike and then a leveling off because all providers, regardless of disciplines or specialty, tend to migrate towards each other. So they urbanize, they go to the suburbs, so they may go to a rural community because of an incentive, but they're going to migrate back. So I think we have a distribution problem in healthcare just more generally that we need to think about. And then I'll just go back, and I say this all the time, and we need to drive collaboration, not competition. And we have to find a way for my members and others to view these as collaborative relationships and not competitive relationships. And sadly, the best way to do that is to get rid of fee-for-service, where they're not competing for the same dollars.
Can I ask a question?
Yeah, Amy, go ahead. Go ahead.
Is that okay?
Yeah.
So one of the things that has been coming up as we have these conversations at the state level and we bring stakeholders together about how do we change the system has been, you also have to look at the medical school training because physicians are not being trained, or even if they are being trained to think about more holistic care, then they go into practice and that's not what's happening. And so there's a gap. And I would be really curious about your perspective on that, and how do we think about kind of investing sort of earlier in the pipeline.
Another really great project for somebody to pick up. So, as physicians become more and more employed, so our, really in the last decade, we've gone from about 35% employed to about 35% independent practice owners. So, just a complete reversal of physicians' economic structures. And what we find through our surveys is a lot of times the narrowing of comprehensiveness or scope is driven by their employer. So they're employing pediatricians, so they don't want family physicians doing
Right.
pediatrics because they have pediatricians, they have
Right.
obstetricians,
Right.
they have behavioral
Right.
health. So somehow, we have to do better work ourselves, but I don't know that it's as much of the medical school and residency programs because they have to do that to get out of there, to become board eligible. I think you just see this massive constriction in the employment market.
In the employment market, okay.
One of the things I want to come back to, and then in a couple of minutes, I'll open it up to the audience as well, and that is the regulatory barriers. There have been a couple of references to barriers that exist at the state level. One of the things we want to examine is what is it that essentially occurs at the federal level that prevents the kind of progress that we'd like to see. In the roundtable discussion, there were a number of things that came up, not the least of which were a sense of competition with the FQHCs and how that's had an impact. But what are, to get to where we hope to be, which is what are some of the solutions, what is it at the federal level that essentially could improve to allow you to do more of what it is that you're seeking to do? What are the barriers at the federal level?
Well, it's the FQHC point. I mean, we were working with a state that was trying to reform how FQHCs were paid. For Medicaid agencies, if they can't bring FQHCs into their VBP strategy, that's a real problem when it comes to primary care and Medicaid. And the state had to seek a waiver, and neither the state nor the Primary Care Association, with whom they were partnering very closely, felt comfortable doing that. So figuring out some way at the federal level to let states who have the buy-in and the partnership of their primary care associations and their FQHCs to enter into some risk-based payment arrangements without requiring a waiver, that would be incredibly helpful because if a state can't enter into risk-based VBP arrangements that provide the flexibility, it's really difficult to really transform only part of the primary care network serving Medicaid beneficiaries.
Are there federal barriers?
You're going to have a program later this weak on Stark. It's not
Right.
necessarily just on
Right.
Medicaid, but there are a lot of limitations that exist from the kind of the Stark laws that I think need to be re-examined. I'm glad you guys are having a program, but it's difficult to collaborate when it's illegal.
Yeah.
Yes, that is.
Interesting point.
And I'll just add, I think to the extent, so a lot, I think as a managed care company, we want to leverage as many existing federal resources as possible that support, whether it's housing or food or, other sort of infrastructures. But the ability to have or for the states to have the option to have flexibility to, either braid or work with the existing grants in a way that makes the money more flexible at a state level, because there's just such conflicting eligibility requirements, and I don't want to speak for Hammy on this, but we find that it would be much easier for us to leverage existing dollars if that flexibility was there, and I feel like that's that's at a federal level. I think the other, I think another thought, one thing that we're, really working with is maternity care, postnatal care, maternal care, postpartum care, and so just flexibility to have, extended eligibility in the postpartum period. Should a state want to take up that option, that might address some of the churning challenges. To provide that continuity of care. So those are just a couple off the top of my mind.
Amy?
Yeah, and I would just add, I would agree with all that. And to follow up on Patty's point, some of the states that have made some big investments in primary care have done it through waivers that they've gotten approval for by the federal government. Vermont is one that has a particularly interesting waiver because Medicare decided to kind of join their primary care initiative. Oregon got a lot of extra federal dollars to allow them to make the type of investments I was talking about in terms of infrastructure and other resources for primary care. And not every state is going to get those types of waivers. So how do we think about giving states more flexibility to work with their plans to make those types of investments. And I think if there was a change that would allow states to do more of that more easily, as opposed to getting a big, huge, complicated waiver that they have to negotiate with CMS, that would be helpful. I don't know if you want to try.
Yeah, I was just going to say, there's a lot coming out of CMMI around primary care payment innovation.
Yep.
But there isn't an explicit role for Medicaid. And so thinking about really how to incentivize Medicaid to align with those models, there's a flexibility issue because it's not exactly apples to apples. But really thinking about ways to bring Medicaid into those payment models as an aligned payer with Medicare, I think that could have a huge impact because, to the degree that it's one MCO or one state trying to change how a single practice is paid, you're not going to get very far if it's just one payer out of 10. And so that alignment piece and really making that alignment easier, I think is really important to think about at the federal level.
So let me open the conversation up to the audience for our last few minutes. Yes. And please identify yourself and put a question mark at the end of your comment.
Michael Cook. I'm a healthcare lawyer in private practice, but I'm also on the Virginia Medicaid board and counseling one of the presidential candidates in the policy stuff on disadvantaged populations and health equity. Got a question for you. A number of years ago,
Yes,
a number of years ago, I asked a couple of panels, how do you get again coordinated care into the poorer communities? Most people were running away from that because we were looking at ACOs and the best answer I had gotten at one point was Denver Health, which isn't the inner city. What we came up with some thoughts. Troy Brennan at CVS actually came up with an idea. If he could integrate his retail clinics with FQHCs, and then you take it one step further and try and integrate it in also into the hospital community that serves those folks. What if you guys, has anybody tried actually trying to pull a coordinated effort like that and start educating the NPs in the retail clinics into coordinating with some of the other services like we're trying to do with primary care practices?
So I'll take a stab. There are a lot of people across the country doing really innovative things. I'm really familiar with a system out of Kansas City because we have our past president, runs the primary care network there at St. Luke's. So St. Luke's has integrated with both community-based and retail-based pharmacy and some local grocery stores, and I don't know, they're just grocery stores to me, of how do they create connectivity with an attributed kind of medical home or, a primary care physician, but then using these satellite, points of contact, if you will, in the surrounding counties of Kansas City, and I think they do about 20 counties for, how are you feeling? Are you taking your medication? Just kind of more check in versus check up type of activities, and they're having some success with it. Now, a caveat to that, they have a lot of federal money behind them. There's CPC Plus practice, they have some private ACOs, they've done some Medicaid contracts, probably with you guys in that region, but they have a lot of money encouraging them to do so. So I don't know how it would work in a traditional fee-for-service if you could motivate, or agitate, movement like that. But there are people doing this all over the country in kind of these, I call them mom and pop innovations.
Yes, to the back. Mike, please.
Thank you. Hi, I'm Christina Nyquist. I spent 18 years with the Blue Cross Blue Shield Association, and now I'm with DTA. And I have an infrastructure question. I think for a long time now, there's been a lot of agreement that the family physician should quarterback the integration team, but that it has to include behavioral health. And sometimes there's just capacity issues with that. So my question is, FDA has a new program where they've cleared digital therapeutics to help with opioid addiction, depression, a lot of behavioral health digital therapeutics have been approved by FDA. And so my infrastructure question is whether or not you have evaluated having family physicians quarterback that digital therapeutic treatment, and if there's any obstacles or barriers.
I can
Yeah.
jump in on that. Yeah. So we are. Thank you for your question. We are very engaged in a number of, or a couple of virtual health technologies, and really working closely with practices to help them with to create that referral, to help them connect to get consultation with behavioral health specialists and other specialists. I think and we see great promise in a number of our populations, our AMBETTR population, the exchange population, and our Medicaid population, with improving access to behavioral health services through virtual health. I think the challenge remains. I think I'll just say, over the past year, there's been tremendous movement and deregulation and statutory changes. I think definitely at the Medicare level, which is trickling down. It really is giving more flexibility, tackling that origination site challenge. But I think there's still some states, I think, still have regulations in place. A lot are very flexible and allow a greater use of virtual health for a variety of services. I think other states, are not as far along down the road. But I think we see the trend's going in the right direction. So I think just having more uniformity in those regulations across states would be really helpful.
Mm-hmm.
And I would just add, we haven't evaluated that, or we haven't looked at that, but as we get more evidence, it would be great for that to roll up to the state level as we think about these metrics that we're trying to think about incentivizing. Right. So I think tying all of that in would be interesting. Yeah.
One of the challenges inevitably becomes preemption, and that is the extent to which you want to standardize. The question will always arise whether or not the feds are going to preempt. And my instincts suggest to me that this is not an administration interested in preemption. And so the question is how they get to that point without essentially the federal government requiring them to do so, or getting in the way of essentially them seeking either through a waiver if they lessen the waiver requirements or whatever it happens to be. But standardization, particularly for plans, I should think, would make things a lot easier to manage if in fact the expectations were similar across the board. Yeah. I had a question here.
Hello, my name is Ted Ganyetz. I'm a family physician, been academic for far too long. And this made me think, why should a physician be a quarterback? And if a physician is not the quarterback, who would it be? I must say, I've been a primary care doctor and a quarterback for a long time, so I don't have the answer, but I think it's we aren't trained in medical school to be quarterbacks, and is it the best use of the medical license?
Okay.
I'm going to leave that.
Wanna
No,
comment? Sean, this sounds like something you ought to take.
I know.
This is, like the future of your employment depends upon this.
Yes.
So I think it's a fair question. I think, are we overemphasizing the role of the primary care physician in kind of this team-based care, and can that or should that be somebody else? So let me reframe it for you. So I think there needs to be a core healthcare team, and I think the services and medical home permeates outward from that core team. Now, whether that's one family physician and 2 nurse practitioners, 4 nurse practitioners and 1 family physician, I think that's community driven. I think market dictates what that structure looks like. I will push back. I think somebody has to be in charge. And I think, the allocation of resources and time and deployment of resources, at the end of the day, somebody has to be accountable for those attributed dollars that are being assigned for that population. I will tell you, I don't think it can be a non-healthcare person. I think, the wrath of the MBA, if you will, I think is becoming more and more of a problem. And kind of these organized delivery structures, I think it has to be a physician or healthcare person that's really driving the care team.
One of the things I want the group to comment on, as well as the conversation we had early in preparation, and that is this question of churn. both churn in terms of eligibility, as well as sort of coverage gaps. Comments on that at all? I mean, that continues to be an issue and always has been an issue with Medicaid, and that is the frequency with which people cycle in and out. Is there a practical answer to that question other than continuous enrollment? I mean, I know this is something we've thought about.
So I would just want to comment, so I know I keep talking about Rhode Island, but they had some really good evaluation results. And one of the things that they found, Blue Cross Blue Shield actually did a study, I think it was of 100,000 of their members, and they found that the practices they had invested in with those payments for infrastructure and practice transformation saved incredible amount of dollars, both on readmissions and just actual going to the emergency room. And so they found even if their members churned, because those practices were more efficient, those practices were still part of their network, and it was worth the investment. So I think if you look at it sort of a little bit more holistically, and I would love Patty's sort of comment on that, because you're in the business, I'm not, but those results, and I think Vermont and Oregon had some similar sort of experiences as well, with investing in the practices then serves the greater purpose of having a more efficient system. So even if you lose a particular member, it's okay, because the next member that comes in is
And Hammy, what were the investments?
They had in Rhode Island's case, they had a per member per month payment just for infrastructure and meeting quality metrics, in addition to what they got for the actual services.
Okay.
So.
Patty, did you want to comment?
Yeah, no, I agree. I think that really helps for sure. And we've seen that. And we have the benefit of both being Medicaid and a marketplace plan, so being able to see individuals be able to transition. I think with that, I think there are challenges with understanding when someone might be losing Medicaid eligibility, and that we need to reach out to them to offer them the opportunity to sign up for an exchange plan. So I think there probably is something more to be done with those handoffs, potentially. I don't know what it is. I think as a managed care plan, I think we can do more to work with providers to try to educate people as they come in to see them, so they can go to the same provider, hopefully across multiple different programs. But yeah, I think I totally agree with Hammy, and also at the eligibility point. So.
Trish, did you want to comment as well?
No, I think there's some interesting examples in how Covered California is trying to manage and make things more consistent that could potentially translate over into Medicaid. And I just echo Patty's point about it's those handoffs and the movement in between and those gaps. Medicaid is also doing a lot of work right now around individuals who are incarcerated and making sure as soon as they are released from jail that there is the data exchange and the infrastructure in place to quickly get them enrolled. It's very focused on that particular patient population, but I suspect that there are some lessons that we're going to learn from that really deep work that's focused on a really high-cost, high-need population that we could then spread to other avenues within Medicaid more broadly.
Can I do a shout out on the justice-involved populations? Because we've just been working with Arizona, and so I like to talk about this model where they had a targeted investment program where they actually paid to have 13 clinics set up statewide that was parole and probation co-located with services for primary care, behavioral health, employment, supportive services, food insecurity, housing, and forensic parent and family support. And so we've been really sharing that model with other states because they have found some really good returns on, someone is going to their probation and parole officer. Here at that clinic, they can get sort of all those services. And the state did that through investments through their Medicaid
Was
program.
it targeted at folks that had been admitted for drug-related issues, or people that were essentially a particularly identified population, or general population coming out?
It was general population, and they're an expansion state, obviously.
Right.
So they have a very efficient way of getting them onto the Medicaid managed care plan, so the plans know who their members are when they need to, but the clinics themselves just provided the service. So yeah.
I'm going to guess that Joy Arpaio didn't set these up, but you needn't comment on
Yeah,
that.
I'm not.
Yes.
Yes.
Thanks, Sheila. Carl Pulzer, a longtime health policy analyst around here, and more relevant, I guess, lately, For the last 5 years, I've been working on a project called the Center on Capital and Social Equity. Two purposes. One is to keep track of the literature and research on inequality, economic inequality, and also advocating for the bottom half. Like, I don't really go after the top 1%. I try to include the bottom half in healthcare. I don't care who pays for it. Doesn't have to be single payer. Sick days, lots of people don't get that, et cetera. So, question. From the Medicaid population I've worked with, they don't have money for the infrastructure to do telehealth. A lot of people don't have, they don't have the money for a cable or to pay for, a phone. Some people I've helped to try to get on Medicaid I gave them a phone, they don't know how to work it. So my question is, yet I see a lot of managed care. I'm in a managed care plan. They're using it effectively, TV and telephone. It would be hard for a low-income person to go to a library and talk about their personal problems, in front of other people. What percentage of people actually have the infrastructure at home to do that in the Medicaid program? And how could you help them get that infrastructure? And for people that the phone might be the most logical thing rather than TV. How would you couple required physical visits and provide them to balance the remoteness of a phone relationship? Does that make sense?
Yeah.
Good question,
All right,
Carl.
thanks.
Thank you.
Yeah, and that's a great question, and I don't have the exact numbers at our fingertips, but we've done a lot of member research, and what we found that actually our Medicaid members, a vast majority have smartphones. Like we're talking almost closer to 90%. I think the challenge is whether they have the data to support a virtual visit. So I think that's something that we're working through, and I would say, but we're in the early stages of really rolling out virtual health visits, but we've had some good success in a few of our markets. I think. So data is a challenge, and I think we're doing some more member research on that. I think the other challenge is broadband access in rural areas, and we are working with, we are looking at some big partnerships to try to expand access in rural areas. So really great point. We are really trying to think through that, but I think that's where things like transportation and ride share. So if they can't actually access a telehealth visit on their phone, it's having the ability to get them to an appointment, and also having flexible hours and things like that.
I can't help but note, as a sort of a final note, that we think in terms of rural, but there are unique challenges in frontier.
Right.
That Osawatomie, Kansas is rural. Outside of Butte, Montana is frontier.
Yeah.
And a whole scale of different issues that are confronted, and both transportation as well as broadband as a variety of other things. We are at an end. Would you join me, please, in thanking our terrific panel?
Thank you. Thank you, Sheila. Thank you, panelists. Thank you, the Commonwealth Foundation. I'm not an expert up here, but I'm taking away 3 Ps this morning. The first P as to barriers. Number 1, providers. We talked about that. Payments system. And number 3, promotion. I'm throwing in promotion on the providers. We're talking about the supply, and whether you're a quarterback or a member of the team, I think it's important to focus on that. On payments, I saw value being talked about, infrastructure being talked about, and technology. All that under the payment system has to be modified. And then finally, I saw promotion, a collaboration with the community and the social services out there are critical. Those 3 Ps to me lead to the bigger P, which is primary care. So thank you all. Thank you all for coming out this morning.